Partnership and Rutgers University. My name is Peter Vuylsteke. I'm an oncologist, and I work at the Faculty of Medicine here and at Princess Marina Hospital. So before we start, there is some housekeeping information. As you can see, this webinar is organized through WebEx this time and not through Zoom for security reasons, and it may give some little problems, so please apologize us for that. Please mute your microphone if that is not done yet, and you will be able to ask questions through the chat function, and a moderator will monitor those questions. This session is being recorded and will be made available after the session on the web. The web name is Beat NCDs, and our webmaster will. I suggest that our webmaster will give you the Beat NCD email through the chat. There will be a feedback survey that will be emailed to you, and please give us suggestions on what to improve and what new topics you suggest. So this session is on ICU care for non-ICU providers. And the first speaker, we have two speakers, and the first speaker is Ed Clune. He was formed as an anesthesiologist in critical care in the USA, and has been working through the Beth Israel Deaconess Medical Center for the Botswana-Harvard Partnership for the past 3 years in the Scottish Livingston Hospital in Molopolole, and recently has transitioned towards University of Botswana in light of the anesthesia residency and in preparation for COVID-19. He's going to talk to us about the basics of ICU. Ed.
All right, can you hear me okay? Thank you for having us this afternoon. We've been given the task of giving a brief guide for non-ICU providers who are providing care in the ICU for COVID-19 patients. A little bit of an outline for my topics today. I will talk about some basics of ICU care, treating hypoxemic respiratory failure, fluid strategies, treating shock, and then a few particulars regarding COVID-19 patients. We all understand the importance of hand washing and donning and doffing of PPE as guided by the Ministry of Health and Wellness guidelines. Ensuring that this is done with a partner or in front of a mirror will decrease the risk for contamination. As in all things in life, I appreciate when things are simple or easy to remember. I have a nice mnemonic for the basics of daily ICU care. I use the mnemonic FAST HUGS. Each of those stands for something very important for each patient during their ICU stay. I'll go through each of them individually. In the interest of time, I'll just make sure I'll kind of highlight each one and the important parts of each. Nutrition should definitely start as early on as possible in the ICU. Can help to maintain gut integrity. And because most of these patients will be on opioids as an analgesic option for them, bowel regimens are very important. And certain folks have been asking the question if feeding can continue through prone positioning. And it certainly can be, only needs to be stopped 1 hour prior to the actual position changing. As I mentioned, analgesia becomes an important aspect of patients while they're in the ICU and intubated. We recommend an analgesia first sedation protocol. It helps with faster extubations and better communication with the patients themselves. Of the available opioids, fentanyl is a good option just because of the incidence of renal impairment that patients endure. Morphine and meperidine, which are other options, can have some adverse side effects if they're maintained throughout the ICU stay. In addition to the analgesia, ICU experience can be very traumatic for these patients, and sedation is often necessary. They should have a prescribed daily sedation score. There are a number of scores out there that are available. The RASS score is just one example, but that should be prescribed and evaluated on a daily basis. Propofol and midazolam are two reasonable options for sedation. But an important point I want to mention here is the idea of a sedation holiday or a break on a daily basis. Doing this allows the practitioners to evaluate patients and see about their readiness for extubation if their ventilatory parameters are within the reasonable limits that I've mentioned here. Thromboprophylaxis, certainly very important, especially in COVID-19 patients, given their propensity toward thromboembolic events. Here you can see I've highlighted Clexane or low molecular weight heparin at 40 milligrams subcutaneously twice a day if their renal function is good. If they have any renal impairments at all, heparin 5,000 units 3 times a day is what the recommendation is. In terms of housekeeping for some of these patients, or most of these patients, I like to see their head of bed at least 30 to 45 degrees, helps with the physiology of respiration, and may help to decrease the risk of aspiration. As I was mentioning before, feeding can help to decrease the risk for stomach ulcers, but due to the fact that some of these patients are going to be intubated for long periods of time, chemoprophylaxis against stress ulcers is also highly likely to be necessary. Therefore, proton pump inhibitors or H2 blockers can be used. Because we're dealing with every other aspect of these patients' bodily needs, glucose also becomes an important thing to take care of. Recommending a range, maintaining a range of 6 to 10 millimoles per liter. It's been shown that ICU patients do worse with either strict blood glucose control or extremes of hyperglycemia. And then lastly, I mentioned the S in the mnemonic is skin and other stuff. Daily evaluations for pressure sores, protocols for frequent turning of these patients as they often cannot turn themselves, limiting the time and amount of central venous catheters that are used to limit the amount of bloodstream infections that these patients can experience. The same goes for urinary catheters, removing them as soon as possible and using them as little as possible. And of course, antibiotics, stopping or transitioning them to a more narrow spectrum will help to prevent resistance in the community. So moving on from the kind of the daily checklist that I'll use, we can move on to treating the respiratory failure that is kind of the important aspect of all these patients for all of us as healthcare providers. So we'll talk about treating hypoxemia and then the certain aspects of acute respiratory distress syndrome or ARDS. In terms of strict definitions, it is characterized by an acute condition. There's bilateral pulmonary infiltrates. A certain degree of hypoxemia is evident with these patients, and it cannot be generated from any sort of cardiogenic failure or evidence of heart failure. As you can see here in the chest X-ray, it's certainly diffuse patchy infiltrates, bilateral in nature, and oftentimes with COVID-19, it's been found to be more in the periphery than some other pathologies that we may be concerned about. And here's just a CT scan that shows an illustration of kind of that ground glass appearance on imaging that is often talked about. It's certainly bilateral, and there's very little open airspace. You can see it's pretty severe disease in this instance. When we're talking about severity of illness, a helpful tool that we use is the PF ratio, or it's essentially the concentration of oxygen in the arterial blood versus the amount of oxygen that we're providing to these patients. So PaO2 to FiO2 ratio. Severe disease, moderate disease, and mild disease, you can see are defined by the ratios as up on the screen. So anywhere between 300 and 200 is going to be mild. Less than 200 but greater than 100 moderate, and severe is going to be anything less than 100. Oftentimes, if you have a PF ratio that's less than 150, that's when you're going to be starting to think about and being consulted for intubation for some of these patients. Intubation is an aerosolizing procedure. That's when you're going to want the full PPE that's recommended, the N95, eye protection, water-resistant gowns, and gloves. Other aerosolization that we try to avoid is going to be with nebulized treatments. We are recommending no bag mask ventilation, especially for resuscitation. It's going to be compression only. If you do deem the bag mask ventilation to be necessary, we recommend a two-handed technique in which one practitioner holds a tight seal over the nose and mouth, while another practitioner actually squeezes the bag. And then a big question that comes up is the use of high-flow nasal cannula or non-invasive ventilation. While not necessarily something that's widely available here, it has been used in other places, often been criticized because of the potential for aerosolization, and it should probably be taken on a case-by-case basis in terms of availability. Using an HME filter is one of the primary things that we can do to help prevent spreading of viral particles throughout patient care areas, especially if you deem bag mask necessary. You can put that filter over the mask or on the ventilator circuit itself. And then inline suctioning is recommended if it's available. So once we have the patient intubated, how do we go about ventilating them? And the idea is to protect their lungs as much as possible and to do as little harm as possible. And that's where we use the term lung protective ventilation, in which we have a few vocab words that I just want to run over real fast. There's, you see on the right-hand side of the screen, PEEP, which is positive end expiratory pressure. And then peak plateau is that PLAT. Both of those can tell us about the state of the lungs and the health of the patient's lungs as in the moment. So what we're doing is once the patient is intubated, we put them on the ventilator and we put them to a volume control mode. And then we can titrate the tidal volumes that they're receiving to try and get to 6 milliliters per kilogram of tidal volume. So in your typical patient, that's about 60 kilograms. It's going to be a tidal volume goal of every breath. Oftentimes you can start at a little bit higher volumes, the 8 mLs per kg, and then titrate down as possible. And that peak plateau, we're trying to keep that under 30 centimeters of water. Again, just protecting the lungs from too much pressure or volume. If you cannot reach that, you can go down on the tidal low of about 4 milliliters per kilogram. Some disadvantages of lung protective ventilation are that it can be uncomfortable, and it can increase the amount of sedation that's necessary. I talked about PEEP, or positive end expiratory pressure, that these patients are going to experience while they're on the ventilator. And that's helping to decrease the amount of atelectotrauma, which is the kind of the expansion and then that these alveoli are experiencing. It does improve oxygenation. It's been shown to decrease mortality. And decreases the need for rescue maneuvers, such as paralyzing patients, recruitment maneuvers, and proning of patients. Some of the bad things about it are that it does increase airway pressures, can compromise hemodynamics, and can compromise some of the healthier aspects or healthier sections of these patients' lungs. So the goal here is essentially oxygenate these patients. We need to essentially understand what are our limitations. So our goal is 88 to 95%, or an oxygen content of about 55 to 80 millimeters of mercury. Therefore, this PEEP ladder, which is from the ARDS network, can help in terms of titrating your ventilator parameters. So if you start on the left-hand side with a 30% FiO2, which is the oxygen concentration, and a PEEP of 5, and you're not meeting your parameters as listed at the bottom, then you can work your way up the ladder to, say, a 40% FiO2 with a PEEP of 8, and then onwards and upwards until you have reached your oxygenation goals. Oftentimes, because we are using lower tidal volumes, it can mean that we're going to have to accept a higher PaCO2 level. Oftentimes, we're going to have to comfortable with PaCO2s of 65 and a pH of anywhere from 7.2 to 7.3, which is generally quite well tolerated. Bicarb infusions are generally not needed or recommended. And in addition to that, hypercapnia may infer some physiologic benefits in terms of anti-inflammatory properties and delivery of oxygen to the periphery. I talked about some of the rescue maneuvers that are necessary, and a lot of facilities are finding that they're proning patients even before they enter the ICU, whether it be in the A&E upon arrival or in the medical wards as they start to decompensate. And just even having the patient self-prone has been shown to be very helpful in terms of staving off intubation or even preventing it. And I just want to touch briefly on some of the physiology of why proning works. Essentially, so in the top two diagrams, you have a cross-section of the thoracic cavity. The left side is a healthy patient. On the right side is a patient with ARDS, and you can see the consolidation that's up on the posterior aspect of the chest on the right-hand diagram. And essentially, what happens here is as you move from posteriorly to anteriorly, you have decreasing amounts of perfusion or blood flow. But if you move anterior to posteriorly,
Just checking in with our panelist group. We lost your audio. Peter, I'm not sure if you can still hear us.
Ventilation to perfusion matching. A little bit more complicated than that, but that's kind of the basic ideas. As I mentioned, proning essentially helps with VQ matching, decreases the amount of lung compression, can improve drainage of the accumulation of bronchial drainage, and then also increases the functional residual capacity, which is the amount of lung that's left over after a breath is taken that still involves oxygenation and ventilation. Another rescue modality that we have is to paralyze these patients. It does improve ventilator synchrony so that they're not fighting the vent as much, causing as much lung trauma, and it also decreases the amount of oxygen that they're using. Fortunately, it does come with a lot of things that are not so good about it. Heavy sedation is needed, increased incidence of PTSD in these, some muscle weakness, and then also, unfortunately, prolongs their ICU stay, potentially taking ventilation capabilities away from other patients. In terms of fluid management, we've mentioned this before, but strategies have been shown to be better in these mortality necessarily, but in terms of their ICU length of stay as well as ventilator-free days. Again, freeing up ventilators for potentially other patients. And then just briefly talking about the treatment of shock. Many of us are very comfortable with this, but our goal again is going to be mean arterial pressure 5. If these patients do have a baseline of hypertension outside the hospital, then that goal should be higher, somewhere in the range of 70 to 75 maybe. And in the essence of a restrictive fluid balance, gentle bolus can help you determine if they're going to respond to further fluid boluses. Also, a straight leg raise can kind of be equivalent to about 300 cc bolus. That patient is going to respond to further fluid, or if you need to start an inotrope. Certainly an echo can help with a bedside ultrasound to determine the amount of cardiac function that they are coming into the hospital with. Again, even to negative fluid balance, oftentimes these patients are getting plenty of fluid just from their nutrition that they're receiving, as well as their other medications, whether they be antibiotics, sedatives, or other pain control modalities. It's been talked about before, but noradrenaline is our first line inotrope. Second line is going to be adrenaline. And if you do reach your blood pressure goals, but you're still realizing that you're not perfusing as well as you should at your end organs or in the periphery, butamine can help to get that, to help move that blood forward out of the heart. This is just a slide that kind of nicely represents how in many types of shock, whether it be hypovolemic, cardiogenic, or septic, noradrenaline has been shown to have fewer adverse side effects than dopamine. And then talking about where we get this mean arterial pressure goal from, we have the definition of hypotension, anything below, certainly a map of 60. On the x-axis here, you can see are your mean arterial pressures. And on the y-axis, on the left-hand side, is the incidence of acute kidney injury, and the right graph shows incident probability of myocardial injury. And as you drop your blood pressures below that threshold of 60 millimeters of mercury, you can see that that's more kind of an inflection point at which time you can see the probability of injury, whether to be kidneys or the heart, starts to increase pretty dramatically. And lastly, I just wanted to mention some of the therapeutics that have been talked about and debated in the treatment of COVID-19. You have corticosteroids, antimalarials, protease inhibitors, nucleotide analogs, and then IL-6 antagonists. Generally speaking, unless there's another reason to be using steroids or any of these medications, they're not recommended. It's only going to be using steroids if you have a COPD exacerbation or something else that would have required them and their use. You may have noticed or seen that yesterday a report came out regarding remdesivir did have a decrease in the time to recovery for the patients in that study, and trended maybe toward a mortality benefit, but we're going to hold off on recommendations until further light is shed on these studies and in terms of recommendations for this. With that, I will end my section and I'll hand it off to my colleague, Dr. Milan.
Thank you very much indeed. We will keep questions until the end of the two talks. In the meantime, you can ask questions through the chat box. So now I'd like to introduce Dr. Alexei Milan, who did his specialization in internal medicine and in intensive care medicine in Cuba, and who has a 20-year work experience in critical care. He's actually employed by the University of Botswana in the Department of Emergency Medicine. Doctor.
Good afternoon for the audience. Okay, the outline of this talk will be a brief introduction on how COVID-19 behaves in ICU worldwide, and as well the COVID-19 in ICU specifically, and how we are prepared at this hospital, SEDATION hospital, to respond to the pandemic. I would like to disclaim that this is based on my own opinion and it does not represent the official considerations of any institution, including the University of Botswana, Ministry of Health and Wellness, and SEDATION Hospital. Okay. At the next. As you know, at the end of 2019, a novel coronavirus was identified as the cause of cluster of pneumonia in Wuhan, in China. Approximately 14% of those patients developed a severe respiratory infection that required hospitalization and oxygen therapy. In those severe cases, COVID can lead to sepsis, septic shock, and multi-organ failure, as well as acute kidney injury and cardiac injury that our previous presenter has mentioned. Okay, in this study that highlight that most of us know that elderly people are the most affected. It means the survival rate is very low on those people, and most of the time is associated with chronic medical conditions mainly cerebrovascular and diabetes. Okay, and this, yes, okay, and no previous. Okay, this one in this from the same study we see here time of the patient start with symptom up to ICU admission is more than 1 week in both group, in main survival and no survival. This slide show how the mortality of those patients within the first was higher than days, but still at 28 days, because the cutoff of those patients was at 28 days, the mortality is still very high at around 50%. This slide as well, this slide show this study published in Lancet as well, show that those patients that went through ventilatory support, either non-invasive or invasive, they have a very high mortality. This means that sometimes look like ventilation is sometimes the causing the problem is not well selected. And this one, if you see as well, those patients, the non-survivor, that is the second column, they had a high index of complication, mainly sepsis, respiratory failure, and acute respiratory distress syndrome, as well as septic shock. Show that a study took a group of patients, 19 of them with COVID-19 pneumonia, and other 15 with non-COVID pneumonia. And they found that through the lab assessment that they can differentiate that most of the patients with COVID-19 had the range of lactic deshydrogenase and alpha hydroxybutyrate deshydrogenase. This means that they look like use that one as a way to differentiate in that pandemic. People can come with other infection, respiratory infection, non-COVID, and they use this thing that sometimes they can use those biomarkers as differentiation. But I should be highlight that all of those patients should be swabbed for COVID-19. That is the one that made the diagnosis. Okay, this slide show a publication. Please, yeah. Okay, they show a serious case. Next. Yeah. They show, sorry, no, the previous one. This one. This study, no, the next one. Yeah, HIV, yeah, the first one, third one. Okay, this table shows a series of cases with HIV positive, all of them. And if you see out of 5, 4 were well viral suppressed. Only one was no viral suppressed. Next one. No, the previous one. Okay. If you see the markers, those ferritin and all of them has severe thrombocytosis, but here was the one that made the difference according to the severity of the illness. It means not the HIV status. It means even though the one that was no viral suppressed had a very high ferritin level, And despite that, all of them, except one that at the time of publication is still in hospital, this patient, all of them, the inflammatory markers were the one that make the difference according to the severity of. And if you see as well, all of those patients, as I said before, had a good outcome, except one that is not at the time of the investigation of the publication is still in the hospital. Regarding ICU readiness to respond to the pandemic, ICU at Cirque to Milan Hospital has been dealing with the organizational issue to respond to it. This ICU is in the first floor in the hospital, and it has 3 sections. Currently, we are in the section C, where 14 beds is allocated, and out of those 14, we have defined a 6th bed that is the one that has an isolation condition to assist the first case in case they present. Regarding staff, currently for those 6 beds, we have currently 3 consultants, 3 anesthesia residents, 4 resident anesthesia, 12 nurses. Out of those 12, 3 of them has a formal ICU training, and the other 9 are general nurses. And we have as well 2 clinical technologists. Next. Regarding equipment, each 34 beds are equipped with ventilator, and 1 spare ventilator for the section C. Volumetric pump, we have 2 for each bed, as well as syringe drive and cardiovascular monitor as well. As well in world suction system and call alert system to be activated in case of any emergency. Extra equipment for section C, as you see is displayed in the screen on the screen. We have other specific equipment for this section. As well, we have conducted very useful simulations that allow us to identify some issue that should be addressed. That I think we are on weekly basis, we are doing those simulations that can allow us to identify those issues that can be addressed. As well, we have been working on protocol, and several protocols has been developed. As you see in the screen, management of needle and stick injury and exposure to blood and other bloody fluids, specimen collection, handling and transportation of those, a strategy to prevent urinary tract infection, use of administration of blood and blood products, vascular catheter insertion and care, proning for ventilation, intubation, mechanical ventilation, sedation, analgesia, hemodynamic support, transfer policy, thromboprophylaxis, stress ulcer prophylaxis, and more. Some of them has been explained previously by my previous speaker. Thank you.
Thank you very much indeed. Now we have 15 minutes of questions, so we are going to unmute you. So please identify yourself and ask a question. I've seen that in the chat function that there's no additional questions during the talk, so I suggest that we can do live questions now. Is there any questions from the audience?
Hi, Peter. This is Rena. There are some questions in the chat box. I'm just going to read it off. CPR without mask ventilation. Can someone elaborate on that?
Yes. Please unmute yourself as well, of course.
That question from Rena?
Yeah, so I believe there's a question regarding CPR without bag mask.
While we are waiting, I have a question. Oh, yes, please.
I just wanted to address a couple questions that I think I saw on the chat function. So the question came up with proning patients and his head of bed up that 30 to 45 degrees possible. And essentially what it's not possible to do it in the regarding when they're supine, but you can do kind of a reverse Trendelenburg of the bed in which while they're prone, you can put the feet of the head down, and then the head of the bed is going to go up. And so you can usually get about 15 to 20 degrees of head up with that. But the bed is not bending necessarily, it's staying flat, but just the entire mattress is being tilted upwards. Another question was regarding the CPR and hands only or compression only CPR. And I think the confusion there is pretty reasonable. And the idea there is that if you do not have an HME filter available immediately, you do not want to be providing breaths with a bag mask without that HME filter available. So if you don't have one available, then you would do compression only. And then once either intubation was possible or an HME filter came, and you have enough providers to do a two-handed mask technique in which you have a reliable seal over the mouth and nose, then you could go ahead with bag mask ventilation with the HME filter in place. Otherwise, studies have shown that actually compression-only CPR is reasonable to perform, at least in the first minutes while extra help is coming toward you. And then I think I saw a third regarding the use of fentanyl for analgesia in the ICU and its relation to chest wall rigidity. Certainly has been seen. And I think as with any clinical circumstance and clinical provider, ultimately you're going to want to go with what you're most comfortable with. So if you are uncomfortable using fentanyl, then certainly other opioids are effective. I think my major point was just to be careful with renal dysfunction regarding the use of morphine and other opioids. Fentanyl not having any renal excretion can be better. And the chest wall rigidity, again, it's a clinical question and can kind of be based on an individual patient basis. I think those are the majority of what I had seen.
So we have a couple.
Thank you. Is there any other question from the audience?
Yeah, so I'm just going to unmute a couple of you who have your hands up. So for Jay Strico.
So while we're waiting, I have a question. So how are we planning to organize it within Botswana if there's a person in a faraway district hospital that may need critical care in the future? How are we organized for that? And there's no ICU in that hospital.
And I mean, I think that's, logistics here are oftentimes our biggest barrier there. And it does become difficult in, the era of this COVID-19 pandemic or otherwise. That's always been an issue. If you have a critically ill patient, what do you do with them? And ultimately, I think it's going to come down to the fact that, if, this issue does come up, it is going to certainly be difficult logistically to be transporting these patients from far afield and getting them to the Circuit Community Hospital. And that's certainly something we're going to have to address in the future. Specifics to that may again come on a case-by-case basis, what transportation is available and what critical care is available in the region where they are.
Okay, thank you. Is there another question that's coming up?
I think people's voices are not
Maybe. I don't see on the chat that there is a technical issue. Or, I see somebody with a hand. Mr. Machosi Macheto, can you ask? You can ask your question.
Bridget,
yes,
she was speaking, but
yeah, we see that you try to speak, but we cannot hear you. That's very unfortunate.
she's muted. She's muted.
We see that Dr. Brigitte is muted and was talking just now. Yeah, Dr. Brigitte Malone. We cannot hear you. We're very sorry about that.
I will not muted ourselves.
No, we cannot hear you. Yes,
that computer that was the one you used with sound.
Yeah, we still cannot hear you. We're very sorry about that. We're working on it.
Robert, can you what's what
I think some of us they picked
Oh, yeah, this one. Okay.
Can you mute this one?
He said that maybe
Oh, we can hear something now.
Zoom anymore.
Malone, can you please repeat your question?
That's the chair.
She should just type it. They've already lost 10 people from them.
Hello.
Yes, we can hear you now.
They've just lost another one.
There's two people talking at the same time. It's very hard for us to hear. Can I suggest that you ask a question through the chat?
Were you asked to do this? Or you were just not asked and they asked Clune?
No, I heard about it, that it was happening, but it's a time when we were, I was very busy.
No, I understand that.
Yeah,
I'm just
so I
saying,
heard about it.
were you asked?
Yeah, I spoke to Clune about it. No.
Santiago speaking, but we can't hear him. Santiago. Yeah. He said his name up there. No. I think they are definitely. It's not as straightforward as a Zoom.
So we're very sorry that we cannot hear you and don't see questions arriving on the chat box. So I'd like to wrap up with thanking you, the audience, and the two speakers for this very precious meeting and your time that you dedicated to this webinar. I would like to also thank the Rutgers Global Health Institute for making this online meeting possible. The next webinar session will be next Thursday, so in a week's time, is going to deal with pediatric and obstetric issues in context of COVID-19. So we're looking forward to that. And we will sort out the technical issues that we're having now with the WebEx, the first time we're using it by then. Again, sorry for that. Please be reminded that there will be a survey to you after this session, and we encourage that you really participate and suggest either topics or technical issues to be solved. Thank you all, and stay safe.